hand it over to you.
Thanks, Tara, and thanks everybody for joining us today. In many ways, this is a continuation of some conversations we've been having over the last few months about the issues around non-physician providers and how the various efforts of Million Hearts can tap into that resource and that sort of care coordination tool, but also thinking about it from the payer standpoint and what does some of that mean. So we've had some discussions about this before. We've talked about it in both a fee-for-service environment where a state Medicaid agency, for example, has new flexibility options for identifying particular services and particular service types that could be delivered on by non-physician providers. And we can talk a little bit about the status of that with states. It's a new option, and at this point I don't know of any states that have sought to take it up, but perhaps it's something moving forward. And we've also talked about it in the area of managed care, where there is somewhat more potential flexibility to use care team models that include both clinicians and non-licensed clinicians or non-licensed providers, which there's not a really good word for it, but we'll call them community health workers for the sake of trying to shorthand it a little bit, but those that are not necessarily licensed physicians or other licensed clinicians. And in the managed care situation, it is, as I said, somewhat more flexible. There are opportunities for services to be delivered under a capitation rate, that meaning the payment from the state to the managed care entity, where the managed care entity can do some more creative things. And a lot of the examples that we see out there right now exist in that environment. And I think there's some other payment models that we can delve into if that's of interest to folks. But I think overall the desire to have care coordination and care teams that may include a whole host of different tools is really something that the Million Hearts Initiative is talking about. And so we thought another conversation among the states in this area about how to introduce that topic and how to think about it from a payer standpoint would be helpful. So that's why we're convening here today. There are a number of dynamics that have to be dealt with when you think about it in terms of things like what do you pay people for these kinds of services? Who are these other providers? How do you make sure that they are in some way qualified for delivering on a service? So if they're not licensed by the state, how are you to know that you have a person who is well trained and capable of delivering a quality service? So these are all some of the issues that a payer needs to be thinking about as they approach ideas to reach into a new opportunity, like including community health workers into the mix. So we have two examples here today, or two speakers here today to talk about this issue. Anne from the Trust for America's Health has been working on this, and Anne, I think I'm going to go ahead and turn it over to you to start the conversation, and then Cherylee, and then we will get into questions. So I hope people are thinking about how this is fitting into their Million Hearts work that they have going on at this time. So Anne, I'll go ahead and turn it over to you.
Thank you, Kathleen. I appreciate it, and it's really nice to have an opportunity to talk with you all. And I really especially look forward to hearing Cherylee and hearing the Q&A part, because I'd love to hear about how this is applicable and what the challenges you foresee are. In the meantime, I'll just kind of give an overview. It sounds like you all have been talking about this, so I don't want to tell you something that you already know. So feel free, maybe Kathleen, you can hasten me along if you feel like the information is too basic for the group. But I just wanted to give a kind of an overview of the rule change and how we see it might be applicable. And just by way of background, TFAH worked to advocate for this rule change a few years back, and then when the rule became finalized this summer, we moved forward with a meeting in October that brought people together to kind of think about what would be the challenges and opportunities in implementation. So that's how we got involved with this here at the Trust for America's Health. And now, as Kathleen said, we've been just working to promote the fact that it's available and encourage states that have models that include non-licensed providers to be looking at whether they would want to submit a state plan amendment, and to be encouraging folks to be working with DMCOs right now to see what flexibility they might provide, as Kathleen mentioned. So that's a little bit about our history and background on the issue. Hopefully, I'm not sure if I know how to advance the slides on here, so can somebody just tell me, do you see the About TFAH slide?
We do.
Yes. Okay, cool. I'm doing it right then. So hopefully you all know who we are. The one report I didn't show on here is our Healthier America 2013, a blueprint for a healthier nation. That included the recommendation to look at flexibility such as this rule change provides. In addition, flexibility around services and sites that services are delivered. This rule doesn't cover all of that, so this is just one tool in the toolbox, I think, that Kathleen was referring to in terms of opportunities for supporting community prevention in Medicaid. But this is a really good one. Some of the other things we'll just see, just to point out, and maybe these are things that you have already talked about. States have been using other tools in the CMS toolbox, including 1115 waivers, direct reimbursement that was added through the Affordable Care Act, such as the quit lines. And then there's the Diabetes Prevention Program, another flexibility and coverage for where the services are delivered and what's delivered in that service package. So there certainly are many innovations in states to look at covering services that are aimed at prevention, that are either in a non-traditional setting provided by a non-traditional provider, or some non-traditional services, such as in the case of asthma. As we know, many states are working to remediate triggers in the home. So that's kind of an overview of some of the tools, and we'd love to work with you to dig deeper on some of those other ones. So getting into this one specifically, CMS did clarify the statute. So this, I wouldn't call this a policy change per se, but really a clarification that they opted to do as a part of the Essential Health Benefits rule. That clarification really just said that Medicaid could reimburse for services that were recommended by a licensed provider but actually delivered by a non-licensed provider. And those are preventive services specifically. Of course, this is a state option, so as you all know, that means it would require a state plan amendment in order to go into effect in any state. CMS would have to approve a state plan amendment. But as Kathleen mentioned, there's a lot more flexibility on the managed care side. So what I'm really going to be talking about is the fee-for-service side. We have listed on this slide, and this is just a brainstorm of different types of lay providers who are currently working in the field. I think there's also opportunity for looking at some different forms of delivering services, such as group visits combined with lay providers under this rule. But would love to brainstorm with you based upon what you're doing in your Million Hearts programs about what types of providers you're using now that might fit under this rule. So these are just a smattering, and like Kathleen said, I think for right now, I think it's good to use community health workers as a catch-all phrase, because non-licensed providers is a bit of a mouthful. Okay. There we go. So what I'm going to do is kind of just walk through really quickly some steps that are provided in a lot of detail in the document that I gave to, I think you all should have gotten before this call, and if not, we'll get it to you after the call. That document summarizes the meeting that we held in October where Kathleen and many of the ASTHO folks were present, and it includes, importantly, a questionnaire that was developed by Nemours. Nemours is a health system and foundation that focuses on children, and they developed the questionnaire to really help folks in the field develop the information that would be needed to go into a state plan amendment. So in talking through these steps, I'm really talking from that questionnaire, and I did want to note that that questionnaire is actually in revision, so there will be a new version of that questionnaire that goes a little more specifically into some areas as we've begun to explore this rule and understand it a little bit better. So look at that as a first draft, what you were provided. So the steps are really just to, basically you need to convince the state or talk to the state about what you're doing and why you're doing it. And that's this way that CMS explained it. CMS really wants states to come forward to them saying, we're working to reduce hypertension, or we're working to improve our cardiovascular disease outcomes. And so that's the whole way you want to come into it, defining what you want to do, and then what is your innovation in care delivery to do that. And I've read through some of the things you guys are doing. It's very exciting, so certainly you have that well under your belt. And then there's all this information that needs to be gathered. I'm going to go through some of that. Then there's, of course, the process of submitting the state plan amendment and a parallel process of working with the managed care organizations. In terms of the health issue, I think the important thing is really describing that intervention very clearly, because by definition it is an innovation in care. So we just want to make it clear about what is different than how the system would normally operate. How are you transforming care by doing something differently? States, of course, want to see the evidence of effectiveness, and a lot of states, for good reason, would like to know if there is a documentation on the return on investment. That's not required at the federal level, but certainly it's always helpful. In terms of the change, specifically, CMS would want to hear about the type of provider you're proposing. So using the catch-all CHW phrase, you would want to talk about that provider. What exact services would they be providing, and to which Medicaid beneficiaries? There might be some guidelines about who's eligible for the services. In terms of the qualifications, this is really important because by definition these providers are not licensed at the state level. As Kathleen said, it's really important that the state have some confidence in some type of qualification process. So therefore, what would the provider's educational background be, their training, experience? Is there any credentialing or registering process in place for some of these lay providers? There are. For the others, there aren't. Also, it depends on a state-by-state basis, for example, in relation to community health workers. And then what's the employment model? Are they self-employed? Do they work for someone else, like the folks in the Diabetes Prevention Program working at the YMCA? What is that employment model? That will get important later on when you need to think about billing. In terms of the service delivery, clarifying what the services are that they're delivering. Again, the evidence of any effectiveness of those services, particularly being delivered by those providers. Very important, what is the referral process? It is a requirement that the licensed provider refer the patient to the community health worker for the preventive service. So how will that referral process work? How will the licensed provider know what quality providers exist out there in the community, and how will they technically complete that process? And we're seeing some cool innovation. Some states are developing some e-referral systems, so we can talk a little bit more about that during the Q&A if you'd like. I saw that you all have a lot of similar efforts underway. The state's going to want to get really specific on what the unit of service is, whether there's any limitations to that service, such as who it can be provided to or where it can be provided. And they're going to need to set a reimbursement level, as Kathleen mentioned. So any cost data that you have or time studies might be helpful in looking at what the reimbursement level would be, since of course we're talking a provider service, not a particular product under this rule. And then I think the most important thing is really, the need to partner and persevere. And of course, your project is all about partnering, so I don't need to talk about that. But the persevering part I think is important, and I think all of us that have been working in this area are being realistic about the time frames for implementation. Of clearly you all have a lot on your plates right now, and this might not be the highest priority in every state, so it'll probably take a year to two, to move the process forward. But certainly there'll be some states that'll be early adopters, at least we hope, none that we know of but now, as Kathleen said, and we can learn from what happens with their state plan amendments. So we'll be getting that information out into the field just as soon as it's available. That's all I've got.
Thanks, Ann. That was really helpful, and I think representing the level of complexity about this, what sounds like a relatively simple tweak, as you said, a sort of an expansion on an existing concept. I really appreciate you sharing that level of complexity. And I think the most important point was actually your first one, which is just the rationale for pursuing this is not that you have an interesting class of providers that need to reimbursement, but that you have to be solving a problem for your payer. It has to be about what is the need within Medicaid for this, and how do you benefit that program, and then you can talk about the providers and their issues. But I think that's really important to start with that very basic step of why does Medicaid need to do this, not why do these providers need reimbursement, is really the most critical sort of conceptual step. Cherylee, do you want to take it from here, and we'll get to questions when we dive back in, or unless there's any sort of clarifying questions for Ann before we move on?
Were there any questions?
Okay, so go ahead.
It's not advancing for me. What do I press? Okay, I'm going to have to tell you to advance it because it didn't seem to work for me.
Shirley, if you click on the slide, there should be a little arrow, and then you can actually click on the next slide. It should be showing at the bottom of your screen, but if not, I can just move them for you.
I don't know what I just did. Oh, I got it.
There you go.
All right. Thank you. Thank you. And my name is Cherylee.Sherry, and I'm really pleased to have this opportunity to share our work that we're doing in Minnesota. As if you were on when Tara first introduced us, I am working from home today, this morning at least. We're pretty close to a foot of snow out there, and we started with kind of rainy ice stuff, which is on the bottom, so there's a lot of cars in the ditch right now. So if you hear cats in the background, they're not used to me being home and talking. So again, I work for the Minnesota Department of Health in the Office of Statewide Health Improvement Initiative, and I work. I've been working on our Community Transformation Grant, and if many of you have heard, Congress basically zeroed it out this year, and so we'll be winding down with that. But as part of my CTG work, I was working closely with our Heart Disease and Stroke Division in regards to working on the hypertension and hyperlipidemia things. I have a master's in public health. I went to NYU, and I'm a certified health education specialist. And I just wanted to say in Minnesota, we probably wouldn't use community health worker as the overall catch-all, because our community health workers are paraprofessionals, and that we have other types of emerging professions, and I'll touch on those just at the end briefly, that have a higher credential for education, etc. And so, so I don't think the other professions would want to be considered being under a community health worker, the term. So I've been at the state of Minnesota for about 5 years. For the first 3 years, I worked on our patient-centered medical home. In Minnesota, we call it healthcare homes, and then transferred into working on the community transformation grant. So when we talk about community health worker, we're using the term as an emerging profession, but it really isn't. I mean, community health worker, the term has been going on for years and years and years. And we really, in Minnesota, didn't hear much about the profession until the late 90s, early 2000s. Hennepin County Medical Center, which is one of our safety net hospitals, was awarded a HRSA grant, and they contracted with the Neighborhood Healthcare Network. And I used to be the director, executive director of a community clinic for many years and participated with the Neighborhood Healthcare Network. But the Neighborhood Healthcare Network, HCMC contracted with us to recruit community health workers, to provide some training. And then what they did is they acted as insurance program navigators. So we stationed them in the emergency department. And for people that didn't have health insurance, we got them on to medical assistance or Minnesota Care right away. And then we were able to get them into one of the community clinics or one of the ambulatory clinics of HCMC to begin that, giving a person a primary care home. In Minnesota, we have quite a few immigrant refugees. We probably have one of the largest Somali populations. We have a large Hmong population. We have a large Latino population, Russian, etc., Tibetan. And one of the things when new immigrants come in, they tend to just go to the hospital. They don't understand our primary care system. And so this was a way to begin to, that we use community health workers to work with the community. So I had the opportunity to help provide some of the initial training. And then during this time, our Blue Cross Blue Shield Foundation of Minnesota had conducted a report about community health workers. And then they provided additional funding for the clinics to begin utilizing community health workers in the clinic system. So I want to talk a little bit about the role of the community health worker. What happened then is a group of stakeholders got together. They were universities, employers, government, convened to strategize about what was needed now to make it sustainable so that community health workers could be integrated into our primary care system. And so this group defined the role of a community health worker, and I have it listed here. You'll get the slides. I'm not going to read through it, but you'll get the slides at the end. I'll send them out to you. Next, then, what this group of people did is develop the scope of practice, and this was identified through a collaborative process. And grants were obtained through our Minnesota State Colleges and Universities, Mankato State, to really formalize a training curriculum for the Community Health Worker Certificate Program, which is now offered at 2 community colleges, a private college, and then we have an online program that's being piloted right now. And there are 17 credits required for a certificate. And as you had heard from Ann, who had just spoken, one of the questions is, well, how are people trained? Do they have a certificate? How are they going to maintain the training? So back in the early 2000s, we were already thinking about this. So when Ann also talked about the length of time, we started this in the early 2000s. And now, I'll speak to where we are right now in a minute. So in 2007, once we had begun began getting people trained, our stakeholders began to work with our Medicaid program to get payment legislation passed. So we really figured out what was needed in the clinic, what people needed for training, and then what kinds of things we needed to do to get the legislation. So in Minnesota, one of our issues was Minnesota is a fairly healthy state. However, if you start looking at the health equity or racial and ethnic health inequalities, it's very, very blatant. And so our white population is doing really well in health. Our minority population is not doing well. And so this was also one of the reasons that we wanted to utilize community health workers to improve the status of all people in the state. So we began our legislation, And one of the things that we did is we needed to add in on our legislation. In 2008, we did receive federal approval for the CHW supervision to the following provider types. So in the beginning, we had the clinician or the physician, and now we added in public health nurses under the direct authority of an enrolled unit of government, and dentists. And then in 2009, we added in supervision by mental health professionals. And then this is just a slide of our legislation. And again, I'm not going to read through it in detail, but it's basically who they're supervised by, and then what they do. And it's care coordination and patient education services. So this is just talks about our payment coverage services. So diagnosis-related order for patient education and the records, face-to-face services, individual or group, standardized. And the CHWs do need to use a standardized education curriculum. And just as a side note, one of the things that we've realized when we began working on, well, how many units are we going to reimburse for, we are trying to promote evidence-based, so this is from the public health side, evidence-based public health, and trying to, in that type of curriculum. So if you think about the National Diabetes Program, and if community health workers can educate that, we didn't put enough in for Medicaid of what we have in the legislation, enough visits, etc., for a patient, because this curriculum goes 16 weeks plus it's X amount of weeks, so it's almost a year long. And so we're going to need to be doing some more work with that as well, just trying to boost up the amount of time. And then here's our payment provider types authorized to bill. So we've got advanced practice nurses, we've got clinic facilities, dentists, family planning, tribes, mental health, physicians, etc. So our experiences, we have now up to now, we have over 500 community health workers that have gone through the certificate program. One of the other things when you asked about, they go through a 17 credit hours and then that's it, there is another organization in the Twin City area that provides quarterly meetings for community health workers to get additional training to kind of keep up on things. We have our CHW available job positions. They've been few, but they are increasing. This role has been really new to the clinic and public health settings, and even though Medicaid is available, some of the other health plans have been laggers on just being able to say, yes, we will reimburse, so more of the commercial products aren't there yet with reimbursement for community health workers. And our lack of interprofessional education means that health and social service providers are unfamiliar with the role. So really, you've got the role, and now it's trying to get everybody on the same page and understand how community health workers can be advanced in working with it. So I did talk about community health for the Hennepin County Medical Center. This is a picture of the community health workers and a couple of the supervisors. That's their team. So Hennepin has, they've opened up a few more ambulatory clinics, but they probably have like seven ambulatory clinics. And then this is just a kind of a care coordination team structure that HCMC uses. So they have a clinical coordinator. Again, it's patient-centered, so patients in the middle, social worker, and then the community health worker. And it took a little bit to get it up and going, but the community health workers now at HCMC are a much valued member of the team. One of the other things, I gave a list of community health worker resources that, there's people ask, well, is there enough documentation on what's the return on investment? Do they improve outcomes? All of those kinds of things. They are starting to get more and more peer-reviewed articles out there. Probably not as much as I would like to see yet, but it's getting bigger and bigger. The other thing is that when community health workers document for their program, the University of Arizona, they've really taken a dive into community health worker program and have a really robust evaluation system, and they provide education to community health worker programs around the country. And so, our group has taken a look at that and has utilized it just in regards to evaluation. So Minnesota has also received SIM grants, so that's State Innovation Model Grants. And so one of the things that we're using the SIM grants for is to advance emerging professions. So we're just not going to take, go to the next slide, we're just not going to take a look at community health workers, but we're also going to take a look at community paramedics, dental therapists, and I think doulas are going to be part of that as well. But we have a request for proposal ready to go out. We're going to recruit a few clinics to hire a community health worker and begin that evaluation from start to finish so that then we can look at process evaluation and look at some outcome data. And then also to build a toolkit. So we'll be doing key informant interviews, etc., to build a toolkit so that then we can really get the word out to other clinics. And then hopefully the payers will be able to have a better understanding of what community health workers or one of these other emerging professions are doing. When we talk about million hearts, community health workers do really, getting people in, medication management, just helping people to be able to understand and being that bridge and connecting people with patients with the primary care clinic. And if additional education, they know who in the clinic to talk to, can help problem solve, all these other kinds of social determinants of health that might be going on. We find also with community paramedics with Million Hearts and looking at blood pressure, etc., that this is, especially in the rural areas, this is beginning to take off with clinics and taking a look at hypertension. So actually in western Minnesota we do have a project going on to take a look at one of the community, and this is through our community transformation grant, to take a look at what the community paramedic does in regards to helping people maintain blood pressure control, especially when they just get out of the hospital. I did mention we have our healthcare homes, so we do have care coordination for payments, so we have that as well. And another project with our 1305, so this is the Department of Health, CDC speak, but it's one of the grants that our Heart Disease and Stroke Division get dollars from. But we are looking at community pharmacists, and then trying to link with PharmD and trying to link with medication management therapy to get some education and get some reimbursement out there. And then you talked about the new CMS rule. Certified Health Education Specialists, I'm sure you'll start seeing that in the next year or two. States looking for reimbursement for that profession, because I know that they're gearing up for that as well. And I think we'll just let the rest, there's my contact information, and if people have any questions.
Great. Thanks so much, Cherylee. That was really helpful, and I think really very telling that just having them reimbursed is only really the first step to having them utilized. And I think that that's really a critical component, because it does involve provider level change, as well as health plans may offer the service or cover the service, but how do you make sure that it actually gets implemented into the systems of care? So you're really just at the horizon once you deal with the reimbursement issue. So really appreciate those comments.
Yeah, and one of the things that helps with the reimbursement, so because when we're trying to promote any kind of chronic disease prevention, everybody says, oh, we don't get enough reimbursement for this. We can't do this. That's what we hear from the primary care clinic. Mm-hmm. And so here's a case where you've got the reimbursement for community health workers, so you reduce, you remove that barrier. So then you begin to look at, well, what are the other barriers? And really it's learning how to work as a team is one of the biggest things. And we find that the clinics that have gone through that transformation of becoming a patient-centered medical home or healthcare home, they've gone through that thinking and working at the top of your license and really beginning to share roles and duties that they're much more willing to take this on. An additional team member.
Yeah, I think that's really incredibly challenging to think about that, and we've heard the same pushback across the board from primary care is I can't possibly meet all of the expectations on me. And one of the things we've been trying to make sure primary care understands that we're not just saying you have to do more and more. We're trying to find resources to help support that very different picture, and the health homes is a great place, and there are a lot of other tools like that in the managed care arena too. Is can the managed care folks provide a more direct loop, all those kinds of opportunities. So, but just a really great thing to think about is once you get through the reimbursement thing, what do you do next?
Yeah, right.
So an opportunity now for
go ahead, Cherylee.
Yeah, right. Absolutely. So this is an opportunity for folks to ask questions of our speakers, to share their own experiences or challenges or ideas that they want to put forward for reaction. So we'll go ahead and open it up for dialogue from the state folks.